Well, good morning. Thank you very much to Paul for inviting Christina and I from Peter Mac to your conference today. That's me. I'm in Peter Mac half-time and in a private practice in Epworth for the other half of the time. Before I proceed, I do have a disclosure. We use any of the funds obtained by anyone in our practice or anyone at Peter Mac into an education fund solely for the use of our nurses. We are short-staffed. We're desperate to turn our nurses into nurse-paying practitioners, and this is how we've chosen to go about it. So I thought I'd personalise our discussion today to discuss where we are and I guess the philosophy of our pain service at Peter Mac, why we choose to do what we do, where we see the problems in cancer pain management, probably expand a bit more on the multidisciplinary management, but you'll hear more from Christina, our totally invaluable psychologist, shortly. I know that you've heard some about interventions, but I think there's a role for further interventions that we're perhaps not, we're slightly overlooking, and probably reflect on our service depending on time at the end. So the philosophy or hypotheses that we essentially work on is that cancer pain management still needs better control. If you look at the studies over the last sort of 5-6 years or so, Europe, America, wherever, the prevalence is still high, and it's still high in terms of severe pain as well. It's not just mild, it's not reporting of mild discomfort. The figures often reflect moderate to severe, and in all stages. And that meta-analysis is from last year, and as I say, is very similar. We believe we have a reliance on a unimodal solution to cancer pain, and we don't adopt the processes of multidisciplinary pain management in cancer pain enough, that we're not chatting to the other medical specialties enough, and that we're not following the guidelines. And I'm sure we're all very familiar with the adult cancer pain management guidelines, the wiki from the Cancer Council, and I'll show some of the guidelines in a second. So the model of cancer pain management that we all use is the WHO ladder. We're all very familiar with it. It has been a very good friend to cancer pain over the years. It's been easy to teach. It's certainly improved the situation from how things were 35 years ago. But it is 30 years old. And if we're going to manage cancer pain well, then surely our model of cancer pain management needs to reflect the advances in oncology over the last 30 years and more of the evidence we're finding in terms of pain and survivorship, etc. Oh, by the way, if anyone's interested, that middle paper, the Ballantyne paper, is a really interesting read from a very good author in the States about where the WHO ladder fits in now. It's reliant on opioids, and opioids don't work in neuropathic pain, and I'll talk a bit more about neuropathic pain at the moment. They have lots of intrinsic problems, so they have problems with tolerance, dependence, and with the sort of oncology advance towards cancer as a chronic disease, then surely why are we still sticking with what is essentially a theatre-type acute pain model rather than reflecting the chronic pain model, which is where we should be? In terms of neuropathic pain in particular, and opioid effects, the literature does vary. People report prevalence of between 20 and 40% at all stages of cancer, including up to 5 years survival for neuropathic pain. And this meta-analysis from Finnerup basically says there's no place for opioids in the management of neuropathic pain. So the reality, of course, is that people have mixed pain syndromes, and that's far too simplistic a picture to say opioids just don't work in this situation. But it does mean that we have to at least consider they may be flawed in a significant number of patients. We also have a community responsibility to start changing opioid prescribing and the enormous misuse that occurs with hospital-acquired and community-acquired prescription medication. Prescription opioids are the most commonly abused drug. And in America, and we're not far behind in America, opioid overdoses accounted for 183,000 deaths and that's prescription opioid overdoses, in about 16 years before 2017. And these are figures from Victoria. We know that overdose deaths are usually a combined toxicity of 2 or more drugs. It's irresponsible just to point the finger at opioids in this situation. However, they do count for 48%, and hospital-acquired or prescription-acquired opioids account for 48% of overdose deaths in the last 6 years, which is a staggering morbidity and, mortality. We, at PTMAC, I think we believe that we're contributing to this problem. And certainly whenever you go out and meet the GPs, they are not irate, but certainly disappointed that the hospitals are sending home everyone on 2 weeks of endone. And we've been part of a multi-centre study. We haven't published this data yet, so it hasn't been reviewed yet, but we looked at 1,200 post-op patients between 4 sites in Melbourne, and we are over-prescribing. 70% of people had leftover opioids at the end of the 2-week mark. 88% of those people were keeping their medication and storing that in an unlocked location, and we're only instructing 8% of people on how to dispose of their opioids. So opioids per se are not the problem, but we shouldn't be giving opioids if they're not efficacious, and we certainly shouldn't be contributing to their availability in the community. So moving on to, I guess, our thoughts on MDT management. Again, from the Adult Cancer Pain Management Guidelines, recommendation 1 is establish a multidisciplinary approach. And obviously that involving all allied healthcare professionals. So that's something we've gone about setting up, and as I say, Christine will talk more about that in a minute. But why do we need multidisciplinary pain management? This is, we just audited about 60 patients attending the Peter Mac Persistent Cancer Pain Clinic. What is psychological morbidity prevalent in this population? Well, it is. 34% of people had moderate, severe, or extremely severe signs of depression, and it was about 28% both stress and anxiety. So there's a very significant, very prevalent population of psychological morbidity in our cancer pain patients. And we get them from the whole sphere of immediate post-surgical to sometimes end of life. So we know that it's prevalent, so that's why we need MDT management, but we also know that the ideal, of course, is always to try and prevent chronic pain in the first place. There are psychological factors contributing to the development of persistent post-surgical pain. So if we treat those psychological factors, then we are preventing the situation, or trying to prevent the situation in the first place, which is a much better outcome than the reality of seeing people 3-6 months down the line already got a diagnosis of persistent post-surgical. That work hasn't been quite so well translated across into the medical oncology and the radiation oncology worlds, but I'm pretty sure most people believe there'd be certainly similar criteria related to chemoneuropathy, radiation neuropathy, etc. So we have to have a multidisciplinary team, and we have to do that because of the prevalence and because of the opportunity of preventing the situation in the first place. I'm just going to touch on interventions and just say a couple of sort of specific interventions that I think we can consider. These are again recommendations from the Adult Cancer Pain Management Guidelines. In your practice, how often are you referring someone for a nerve block or considering an intrathecal infusion? You don't have to answer that. From a PTMAC point of view, almost never. We have put in 2 intrathecal ports in the last 2 years, and that completely defies the guidelines and the recommendations. If you think about those terms as well, of difficult to control pain, diffuse pain, or unacceptable opioid-related toxicity, that's a very significant population. Now, clearly, the majority of people who meet this situation don't need an intrathecal pump. But are we actually still considering, and are we making available for people, no matter what their geography is, or their insured status or whatever, the ability to have these interventions if required. We're not doing that at the moment. This is the flowchart from the same guidelines, and again, interventional has a clear role in those 5 methods of pain management. So, what should we intervene with? Well, in many respects, just bringing up the potential for intervention is just really flagging someone who has refractory pain and therefore needs a bit more thought and a bit better management. And this first paper comes from a study in British Columbia, I think it was. And all they did was create a multidisciplinary collaboration. And that involved radiation oncology, pain, palliative care, and I think one of the medical oncologists. And just by bringing people to that forum, and some of them needing blocks or interventions, and the majority not, the average mean worst pain score reduced from 8.1 down to 4.6 for those presenting in that forum. So there's benefit to just flagging these patients for a start. There's all the other benefits as well of interventions that we perhaps don't think about. In Victoria, obviously, at the moment, untreated pain leads to requests for suicide. Well, we've got a pretty thorny issue to deal with in Victoria. Surely if we can manage pain even better, then perhaps we're reducing the number of people who will be requesting physician-assisted suicide. There's financial gains as well, including unnecessary hospital admissions and visits to ED. So, again, I'm not going to exhaustively tediously go through all the different interventions. We can use them as single sort of modal treatments, or use them as part of a paradigm. And the paper on the left is an interesting study of thoracic chest wall pain, and how you go about using interventions as part of a paradigm in that, depending on the anatomy. But the slide on the right is quite an interesting lady who had a severe radicular pain from sacrally invading colorectal tumour. And she was from Melbourne and needed to come up to RPA for a segmental sacrectomy. Her pain was so severe that she couldn't get on the plane. She had an S1 epidural, which is what you can see on the right. The dark lines are the contrast outlining going into the foramen at S1 and going up and down the nerve route. And it wasn't particularly fantastic. Produced about 30% analgesia for about 3 weeks. So if we're looking at pure pain relief, then a block is actually not that valuable. But in this situation, that was enough to get her on the plane and get her on to have further treatment. So we have to sort of think more globally of pain outcomes in this particular population. Spinal cord stimulation. This is a Faculty of Pain document and position paper from 2011, and they define the 3 categories of indications for spinal cord stimulation: conditions likely and conditions that may. If we think about the different cancer pain syndromes that we can get presented with, then at least one of the conditions likely and 2 or 3 of the conditions that may well respond to spinal cord stimulation. And again, this is just not really under consideration for many of these pain syndromes. Intercostal neuralgia from thoracic pain is something we see all the time in clinic. Brachial plexopathy from metastasis or from radiotherapy is extremely common. Neuropathic pain secondary to nerve damage, again, extremely likely. So what's good about spinal cord stimulation? Is it just more sort of boys with toys doing interventions and not really thinking of the outcomes? Well, we're very fortunate with spinal cord stimulation in one respect, that most people have a trial phase of spinal cord stimulation. So 2 epidurals that are put in, and they have little electrodes on the leads, rather than the normal sort of labour ward epidural. Excuse me. And those electrodes are programmed to produce paresthesia over the dorsum of the spinal cord, and that is then mapped to the area of pain that they experience. Now, if you apply it in the right person at the right time, after proper psychological management, a trial is only positive and a patient will only go to implant if they have 60 to 70% pain relief. A lot of the pain studies that we look at, we talk about VAS score reduction of 2 as being quite a successful outcome. So these can provide significant analgesia. They are far from the panacea. They should definitely not be used unnecessarily. But to have something that we can at least try first before doing something permanent is a really valuable thing to be able to do. The second phase is the implant. You can see the implant on the... usually we put them just above the buttock. And it's essentially a fancy pacemaker, and that's all it is. Then moving on to intrathecals, and I think Charles spoke probably earlier about intrathecals, but we must think of intrathecals in terms of the guidelines, and again, those indications are extremely common, but again, absolutely, that not every one of these patients needs an intrathecal pump. That just is not realistic. Most of the studies of intrathecals are sort of case series or getting on a bit now in terms of age. But these are a couple of interesting studies from 2002. And in particular, we should think of analgesic techniques as ways of reducing toxicity and not just ways of reducing pain. These studies use slightly older paradigms for intrathecal analgesia that we would hope to have improved on since then. But in terms of their studies, 30% of patients who were... Actually, I'll go back a bit. So it was a randomised control trial of 200 patients diagnosed by their oncologist as having a 12-month prognosis. And on the start of their entry into the project, their oral morphine equivalents averaged out to about 200 milligrams per day. Within a month, the toxicity ratings for the intrathecal group had dropped in the order as you can see on the right-hand side of the slide. Their analgesia had improved in terms of 57% compared to 37%, but the individual toxicity ratings had dropped enormously. And that's probably because it is just a fancy way of opioid rotating. And this is therefore something that should be considered only after reasonable rotation attempts have been tried. Within a month of the people entering the group, the intrathecal group, their oral morphine equivalents have dropped to the equivalent of 50 milligrams per day. Within a month of starting the conventional medical management group, their oral morphine equivalents have gone from 200 to 250 milligrams. And they had had at least 2 to 3 rotations prior to their entry into the program. One of the biggest implications of intrathecals that is always sort of talked about is the cost of an intrathecal. Are they cost effective? Are they hugely expensive? Why are we even considering these techniques? Well, actually, according to this study from 2013, in refractory cancer pain, they become cost-effective at 7.4 months. So there's obviously prognostic implications to who you should be putting an intrathecal in. But 7.4 months is actually a pretty reasonable, that's what I'm looking for,